Should I go first?
Yes.
Do it.
Okay. Will you allow screen sharing, please?
Oh, yeah. Oh, wait, go for it.
On the bottom security, yeah.
Do you all see my screen okay?
Yep.
Okay. Okay, young female with pelvic pain, and as I said, it's a quick show and tell case. Just saw it recently, last week. Do you see my images? I'm scrolling the images, you'll see that. I'm not sure which screen I'm sharing at this moment.
Axial.
Yeah, okay. That's the right screen. Any thoughts on?
For me, it's kind of like jumping around a little bit, but I'm seeing.
Oh, should I scroll it more slowly?
Maybe.
Okay. This is the coronal, like an oblique coronal.
I think it's probably unicornuate with a functioning rudimentary horn.
Mm-hmm. Yes, yeah. It's just as I said, it's a simple case. So it's a unicornuate uterus, and we see another uterine cavity here, but there is no communication of this with the main uterine cavity. So this is the unicornuate uterus with a non-communicating rudimentary horn. And an important thing in these cases is to tell if this rudimentary horn has functioning endometrium or not, because that has important clinical implications. So in this case, the functioning endometrium is there, and presence of functioning endometrium results in like fertility issues, a lot of pregnancy related complications. So it's important to mention that part, because this rudimentary horn may or may not have functioning endometrial tissue. And just a few more images of uterine anomalies. Moving to a presentation. So what do you all think the diagnosis is in this case?
A septate?
Yes, so that's a septate uterus. This one. I think these are, I think, easy. So this
Arcuate?
one.
I want to say arcuate, but it needs to be 1.5 centimeters below the. Or
Yeah, I mean, it's not that great. It's just a mild. I know we have to measure the distance. We draw the intercornual line, and if the dip is more than 1 centimeter is when we say it's a septate uterus. And then this case. This will
it's like a
uterus. Yes, so it's a bicornuate bicollis. So the cervix is also has a septum in between. So bicornuate bicollis uterine anomaly, and that's the classification of uterine anomaly. We saw a case of unicornuate uterus with a non-communicating rudimentary horn. We saw a case of septate and an arcuate uterus. And here is a comparison. The other thing is that these 3D T2 images really help in these cases, because so that you can reconstruct the true axial and coronal planes of uterus if you have a 3D image. And the important thing to it's important to differentiate a septate from a bicornuate uterus, and the most important thing to look for is the external fundal contour. If the external fundal contour is preserved, then it's either going to be arcuate or septate uterus, and if the dip is less than 1 centimeter, it's arcuate. If the dip is more than 1 centimeter, it's septate. And sometimes this septate uterus is a complete septate, like the septum goes all the way to the cervix. And in those cases, sometimes some people may confuse it with a bicornuate or a didelphys. But again, the important thing is to look for the external fundal contour. If the fundal contour is preserved, it's a septate uterus. And then in bicornuate and didelphys, you get this fundal dip. I mean, there is no upper convex concave fundal contour. So if you see a dip in the external fundal contour, then you're thinking of bicornuate and didelphys.
Gitanjali, I have a question. To get these beautiful coronal images,
Mhm.
Are you doing like a coronal, like an oblique through the long axis of the uterus?
No, that's what I said. We do a 3D space, T2
Oh,
space
okay.
sequence, and then reconstruct it in the plane of the uterus. Otherwise, it's very hard to get because it will always be flipped to one side. So either the tech knows how to like give angles twice, or it will be a complex thing to plan out. So we just do a 3D T2 space sequence.
Nice, beautiful.
That's all from my side. Stop share.
Teresa, do you want to go? And you have to
Sorry,
tell me what
yes.
happened with your gallbladder case that we were texting about.
Oh, you know what? Wait. I think our final thought after reviewing it with Cookie as well is that it may be related to more inflammation, like an IgG4 process. It did look like there was some enhancement of the extrahepatic bile duct or the common hepatic duct. So we still need to get further follow-up, but we were suggesting that they should, do steroids, and someone else had said that it was, I'm blanking on the name.
Xanthogranulomatous?
Yes, and we decided it was definitely not that, so please don't send to surgery.
So the more important issue was that it was probably read without the knowing that the patient has been seen in an outside hospital and they've done 2 ERCPs and had imaging. So the gallbladder can look very funky after ERCP and then mucking around. So, and no one was talking about that on the outside reports. So it's got to be something that had happened as opposed to this one time point. The gallbladder looks so ugly. So it was just more important to get the outside films to compare.
Cool.
No, can you guys hear me? Yeah.
Yep.
Okay. All right. See these 2 images?
Yes.
Yeah. Okay. Anyone want to go? So the findings aren't intra-abdominal.
So she has all that soft tissue like stranding in her abdominal wall. Kedar is asking if the patient is diabetic. Like, could this be related to an insulin pump?
Not the pump. So yes, the patient is diabetic, but this is not related to an insulin pump.
Is it like a diabetic lipodystrophy?
Yes, lipohypertrophy. So these are from insulin injections, and they, usually alternate sides, and so it causes this focal. They call it lipohypertrophy, but that's kind of a misnomer because it's not the fat that's enlarging. It's the soft tissue here, the stromal enlargement, and so they can kind of look like abdominal breasts almost. And I think Cookie wrote a paper on this.
Teresa, tell us more. What do you mean by stromal hypertrophy? Like, that soft tissue we're seeing is actual, like, what is that?
It's not stromal.
Sorry, not stromal.
It's not stromal. It's some sort of, I don't know what actually the soft tissue component is, but it's been biopsied several times because it can, like for example, this paper, and Steve talked about it, this is Perry's case. So you can see they look like abdominal breasts, and they can be quite soft tissue in nature. If you scroll down and trace it to the 3D, which I was trying to do the 3D for this case, it can be quite marked on it. And, the key in this case is to see that the patient had a renal transplant. It's a nice case too as well, to link it all together. I'm not sure what exactly causes the soft tissue attenuation with the insulin injections. And it's not everybody who has this. It's some sort of weird secondary response to this for insulin. I mean, we have so many people who are on insulin, but some people have this and the majority don't.
Very cool. Steve says Perry showed it, or maybe she showed the same case at SAR last year.
Yeah. So he showed it.
And one of the hypotheses that I had read, I'd like to add something, is when we inject like insulin, the local insulin concentration is higher, so it causes increased glucose uptake by the cells surrounding it, and that's why there is irregular hypertrophy, atrophy of the tissue surrounding it. I mean, that's one of the explanations, like we see, like when they started describing this term lipodystrophy, insulin-related lipodystrophy was the term was described once for these changes. And it's all because the local insulin concentration increases and there is increased glucose uptake by the surrounding cells, and there's like hypertrophy of the surrounding tissues.
But what does the surrounding tissues in the fat? That's the question.
Okay, yeah, that probably is.
I mean, I don't know how to answer that, but yeah. Anyway, it's just something to keep in mind if you see that going through, that this is what it is. Abdominal breasts.
Cool. Ben, do you want to go next?
I'm going to stop.
Yes, I'd like to share a case. Can you guys see my screen?
Mm-hmm.
Okay. So I'm going to show a CT. Then I'm going to follow with an MRI. This was a CT that was read in an outside hospital on a young patient. Everybody can see that she had a cholecystectomy, but she has these hypodense lesions in the liver. These were misinterpreted at the outside institution as intrahepatic cysts. So then she came to us in the interval between this examination and the MRI that was performed. Yes, I agree, Dr. Eberhardt, these are not cysts. Between this examination and the patient coming to us for the MRI, they actually ended up performing a biopsy. And this is biopsy proven for the entity that I'm going to show. But I wanted to show the T2 sequence on axial and coronal. Specifically, I want to bring your attention to these peripheral subcapsular based lesions that have a little bit of
Epithelioid
retraction. Yes. Wow. Yes. Correct.
It's classic.
This was a good case, so I wanted to kind of share it with the group. So basically, if you see this appearance, you should think about this rare entity, epithelioid hemangioendotheliomas. And this is actually biopsy proven. We took a look at their biopsy results, and this was confirmed when the patient was biopsied. So I wanted to share that with the group. That's all I have.
Great case.
My resident I'm sitting here with asked me, do they matter? Ben, what do you think? What do we do about these lesions?
So this patient is actually getting a transplant.
Yeah, they get
so they do matter. And to Dr. Eberhardt's point, you don't need a biopsy for this necessarily, because this was kind of the classic imaging features for this entity, which is why I'm sharing it with the group. Sometimes it can be a little bit more difficult to be definitive, but it's nice that we have a biopsy, especially because of the confusion that was generated by the outside report.
Nice case, Andrea. says.
Thank you.
Yeah, and then some of them can be stable and some can be progressive. So sometimes we have a few in our system that we're watching, but then when they start progressing, they might lean towards transplant, and some can also be metastatic. So they have very variable malignant potential.
I have a quick question. I mean, the fact that you jumped to this diagnosis because the patient was young, multiple peripheral located, I mean, do they have any, besides that lollipop sign, do they have any other enhancement pattern?
Not 100% sure, but I think part of the reason that we went to this was we were fairly certain this was not, given the patient's age and the appearance on T2, we were fairly certain that this was the diagnosis. I'm not 100% sure about the enhancement pattern. I can look that up and get back to you.
Hey, Aarti.
Yep.
Would you mind if I just quickly showed a companion case? I have exactly the same case.
Oh yeah,
Oh,
absolutely.
wow, cool.
Well, then I have a companion pitfall case that I'd like to show after that.
Okay, this is awesome. And while Kedar is pulling his case up, Ben, I think that Cookie, correct me if I'm wrong, but they often have this targetoid enhancement, and
There you go. You can see it.
Yeah, targetoid enhancement and the capsular
Wow.
retraction and multiplicity as well.
They all look the same. They are the two cases I have seen. Both have gotten transplant, and both of them have been young women.
Kedar, can you show us, does it change between the arterial and the venous? Does
Yeah,
the
actually,
rim
I
have
can.
more delayed enhancement? I can't remember
Yeah,
which
one
one.
second. So this is the arterial phase.
Yeah, some people say they can mimic hemangiomas because they're fill in more.
Yeah, but I mean, they have this peripheral non-enhancing rim.
Yeah.
So, and then this is the very delayed one. So they have this typical a reverse target or targetoid type of an appearance, which both, actually 3 cases we've had, and they all looked the same. And this is a very delayed scan.
Quick question. Are these always multiple?
Yes, always multiple.
And I think other thing to notice is here the arterial enhancement is in the center, and I think the delayed enhancement is more in the periphery of the lesion, right? Yeah.
That is correct, yeah. Okay, that's it.
Okay, and I'll quickly show my pitfall case. So this is the axial T2 fat set, again, targetoid
Wow.
lesion. This is the arterial phase. Look ugly, but there was capsular retraction. Let's get rid of these.
Gitanjali, I'm guessing neuroendocrine mets.
Yes, these are neuroendocrine meds. The only thing is this, they also showed in delayed enhancement, fill in and capsular retraction, those were the two similar findings, not similar, contrasting findings, but they showed fill in. But here the fill in is more in the center, and in endotheliomas, the fill in is more in the periphery. And then obviously these are more, this was a 77-year-old patient, and hemangioendotheliomas are more in younger patients. So that's a differentiating point. I mean, there are differences, but this almost looked like if you didn't pay attention to the closer, smaller details, where is the enhancement, where is the arterial phase enhancement, where is the delayed fill-in, then you can get fooled. But this was an elderly patient. This patient had a known history of neuroendocrine tumor. They've had distal pancreatectomy. That's where the primary neuroendocrine tumor was, and these were all neuroendocrine mets.
Nice. And then Nellie's saying that she's going to go next time. Anyone else have cases, or I can show mine? I have 4. Okay.
Teresa has another, she said.
Aarti,
Okay.
I also have a case when you get a chance.
Okay, great.
Should it? Okay.
Can you guys see my screen?
Yeah.
Okay. So this is just a little bit of a show and tell case, but this was a patient who was quite sick, and you can see the gallbladder is full of stones, and there was actually this frank rupture of the gallbladder here with all this fluid in the abdomen, and you can actually even see some stones layering in the gutter here. So I'd just never seen a gallbladder perforation kind of fill up the abdomen with this much bile and this much like extravasation of stones with like the actual location of the perforation seen here. I can't see the chat box.
I mean, the 2 cases I've had of gallbladder rupture have been cancers.
Oh.
So I don't know what that iso intense gray, evil gray looking thing is there.
This guy here?
No, up, and yeah, exactly right, in that neck.
Yeah, interesting. Okay, well, he's not a surgical candidate, and they put drains in, and I wanted to show the post drain. And so actually, this is now the decompressed gallbladder with the stones in it.
Yeah, there's some enhancement.
There's the rupture there, yeah.
There's some abnormal enhancement to that wall, though, if you go back up to there.
Yeah.
So just anecdotally, my 2 cases I have,
yeah,
my T25 have been underlying cancer.
Yeah. Great thought. We have not yet investigated that. We just kind of said that it was a perforation, and then IR put some drains in, and you can actually see that a lot of most of the fluid is gone. So I was pretty impressed by these drains. And when I first saw these drains, I thought they were like surgical drains because they don't look, like the little pigtails that we usually put in. But anyway, they put in a biliary drain, and they even added in like extra holes. And so they're able to like remove most of that fluid. So even if you have
it's like a hose.
What'd you say?
It's like a hose.
I know. I like it. So I was impressed.
I mean, you can get a CA19-9 very quickly added to the labs.
Yeah, definitely. Great. My next case is this one. So this patient had this large mass in their abdomen. Actually, maybe I'll keep it this size. So you can see it almost looks like it's communicating with a bowel loop. It has a lot of central air and fluid with like a thick rind here. Any thoughts?
I mean, a malignant gist, a melanoma met.
Yeah, exactly. So I was thinking, I was favoring a gist, maybe of the like proximal, like the small bowel here with communication with the bowel loop. Somebody brought up lymphoma, like could this be aneurysmal dilatation of the loop? That would be pretty aneurysmal. But anyway, the clue was actually in there. So this ended up being a myxoid liposarcoma. And my sarcoma surgeon always tells me that myxoid liposarcoma is not a true tumor of the abdomen. It's usually a met from the extremities. And in this case, this patient actually had this in their leg. So you can see that there is this very T2 hyperintense lesion, and it actually demonstrated a lot of enhancement. So this was the primary tumor, and then the thing in the abdomen was the met. So you can see it has, even though it's really T2 bright, it has a lot of enhancement. So that's like the classic kind of myxoid lesion of the extremity.
Do we have an MRI of the met?
No, of the abdomen, no.
Yeah, so to see if it has the same type of a signal.
Yeah, no, we weren't even, I mean, liposarcoma was not even on my radar here.
A met, obviously, met, you would have said met if we knew the primary.
Yeah.
That's great.
Yeah. Next case is this one. So this is a patient with this fatty lesion in their adrenal gland. It has some dystrophic calcifications, but it looks kind of like a classic myelolipoma. And because it has this like bulk fat and then the smudgy stuff, that's like the myeloid components. And on the out of phase, you can see that like there is that interface and loss of signal where the fat is interfacing with the myeloid components. Whereas back here, where there's interface between the fatty lesion and the fatty retroperitoneum, there's actually no interface there. And just as a companion case, because my resident was asking me like, how can you tell this isn't a liposarcoma? I do have a companion case. This one was a fatty-esque lesion affiliated with the adrenal gland, but you can see that the adrenal gland is kind of next to it, and this thing is kind of like encasing the adrenal gland. And at this point, we actually still thought this was a myelolipoma, but within a year it had grown quite significantly. It's having like a lot of mass effect on the liver. And so we biopsied this, and this was a liposarcoma encasing the adrenal gland. Any other?
That's a great pitfall. That is a great pitfall, actually, that specific case, because I would have called that myelolipoma in the first.
Yeah, yeah.
I mean, I guess it is surrounding the whole thing, but I don't know if I would have thought that looking at it originally.
And then actually going back to my, oh, go ahead. Somebody was
I've had some cases that are a little squirrely. Like if the I think one of the key things that I picked up over the years is the first one you showed is pretty well circumscribed around the margins of the lesion, whereas the second one you showed kind of was a little bit irregular around the margins, and it would have made me a little bit more nervous.
Yeah, yeah.
You
more
can
like multifocal
these and differentiate them. They can tell a myelolipoma on biopsy.
Yeah, and then liposarcoma we have to send for MDM2 to make sure that can help with liposarcoma. Back to my thing, I was asking the surgeon, like, are you going to resect this? So, and then like, why do we resect myelolipomas, for example? And he said, usually after they get above 6 centimeters, they're concerned for hemorrhage and rupture. And so that's like the main reason they resect them. And then on Radiopedia, at least it said that 10% of these, even though they're not hormonally producing, about 10% are associated with endocrine abnormalities, including like Cushing's and Conn's disease. So I don't know if it's like inducing it in the adjacent or whatever, in the leftover adrenal tissue, but the myelolipoma itself is not producing the hormones. But so in this case, the patient is having like hypertension, et cetera. So he's going to resect this.
A quick question. Sorry.
Mm-hmm.
So that calcification, can we have that? Like initially, I thought maybe this is those big exophatic gross RCC with gross fat. Can we have that much calcification with benign myelolipoma?
I think, I think so. And you can definitely have calcification with myelolipoma. And then this one, it's not coming from the kidney. But the other thing you think about with calcification in the adrenal is adrenal cortical carcinomas can have calcs, and that makes me more alarmed when I'm debating between a pheo and an adrenal cortical. But those tend to have like central necrosis and then calcification in the central area. So this really didn't look like an ACC to me.
I have a weird case from WashU where I had a sickle cell patient who had a myelolipoma, and they had a follow-up MRI, I guess 5 years later, and it was like 3 times the size. Huh. So I didn't know if it was something with the bone marrow.
Ooh,
changes
extramedullary hematopoiesis in the myelolipoma.
Yeah, sickle cell disease. I mean, I couldn't find anything in the literature. I have it as a case, in my teaching file, but I was not able to find anything in the literature about that change in the extramedullary component of the bone marrow elements. Has anybody seen anything like that?
I could see that, or even like brown fat proliferation in the fatty part. I don't know.
It was all fat, but it was double. It actually went to resection because the surgeon was like not comfortable with leaving, a growing, significantly growing fatty lesion. So we have path that's a myelolipoma, but
cool.
Kind of interesting.
And then this is my last case to inspire us all. This is a patient who had this hepatomegaly, and I'll show you that they have severely fatty hepatic steatosis. You can see how big their liver is, and very fatty. So in phase, out of phase. And this is just 4 months later after exercising and stopping drinking. And you can see that their liver has significantly recovered. So this is in, out of phase. So I didn't realize like how quickly you could recover, but it was pretty impressive. We were all amazed and inspired to go out and have healthier behaviors so we can fix our liver. I was looking it up. And so patients who have undergone gastric bypass, they can, like 66% of them can completely resolve their fatty liver. Other patients who have like undergone weight loss, within a year, they can, completely resolve their fatty liver. So
I have also a companion, not a case, just for myself, because as part of a research with Claude, I scanned myself like 100 times. And as you just said, it's
That's hilarious.
extremely respond to the diet, as you said. It's immediate to respond. That's
Did you
my
just say you've
personal
scanned
experience.
yourself 100 times?
Yes, I was basically a human phantom.
Awesome. So you're like, try different diets and scan yourself again? That's awesome.
Yes.
I've seen some alcoholic steatosis disappear pretty fast on like trauma patients.
Cool. Like after they've been traumatized and are now an inpatient.
Yeah,
can't drink
exactly. And they get their follow-up CT like 2 days later, and it's like almost normal again.
Cool. Okay, I think a couple of other people said they had cases.
I can share a case. I have a kind of a show and tell like you had.
Yeah, go. Okay, Steve says he's having problems with his connection. So I think Victoria said she wanted to go.
Yeah, I can go. Hopefully I'm not gonna get that stupid. Okay, can you see my screen?
Yes.
Okay. So this is a very interesting case. The patient came in with a history of trapped clitoris versus clitoral tumor. And I still couldn't figure out, if anybody knows what trapped clitoris means, please let me know. I was unsuccessful in a Google search. You can see that in the region of clitoris, there is something. There's a lesion, ovoid, very dark on T2. Oh no, come on. Oh, yeah. Hold on. I'm so sorry about this. I still can't figure out why this computer does this. And it was very bright on T1. And subtraction images showed that there was no enhancement. So I don't have the path for this, but the entity that I found that can look that actually not radiologically, but in general, there's an entity called Epidermoid cyst of clitoris, and this is the only thing that I could find that fits this imaging finding. So I think that's what it is.
Did it restrict for epidermoid?
It did not. Hold on. I'm so sorry.
They weren't injecting anything in their clitoris, right?
No. So no.
Good thought.
Is that it? Okay.
But do share with us the reasons why somebody would do that. I'm very curious.
Is that a thing? I mean,
I think it could be a thing. People do all sorts of injections.
Huh. Interesting.
She's older. She's in her 60s. No, the history.
Becoming less likely.
Yeah, the notes is that she's had a mass, and it's slowly growing over the years, and now she decided to come seek the attention, medical attention. And clinically, they found this mass, and based on clinical description and based on the case report that I've seen of this epidermoid cyst of clitoris, it fits the physical description. So like this ovoid firm mass that's mobile. And in her case, they also said that she had like adhesions of the clitoral hood. So I assume that's what they mean by trapped clitoris. But again, if anybody has any better knowledge, I'm happy to hear it. There was no restricted diffusion, as you can see here. So let me see if I can get the subtraction.
Do you think the GYNs are going to go solve this for her?
So I haven't, and this is a subtraction, so there's no enhancement. So based on again, there are some case reports on how they manage these, and it seems like they have to unroof it and take it out. But the difficulty here is that they want to preserve the sensation of the clitoris. So I think that's the tricky part of the procedure. It's possible that you know, that if she knows that this is not cancer, she just leave it alone. Because you know, because I think that the reason why her main concern was she was afraid it's a cancer, understandably. Okay.
Maybe another term for trapped clitoris is phimosis of the clitoris.
Maybe.
I did look up, and according to Wikipedia, there is a market for clitoral enlargement.
Naturally.
Okay.
I mean, who knows if it's self-stimulating?
I mean, I have to say that when I was trying to figure out, like searching on PubMed for, you know, clitoral epidermoid cyst, a very interestingly titled article came up, and I can't really say because it's highly inappropriate when applied to a human, but it was actually quite appropriate when applied to a female dog. So if anybody's interested, just you'll find this article quickly. Okay, moving on. So this was just so the case I'll show you is a complication case, not an eye test by no means. This patient came in and they had a history of cholecystectomy at outside institution. And we're still not sure how they managed to do the damage that they did, but based on the report, they transected the common hepatic duct, and then they had to reconstruct the portal vein. So somehow during the surgery, they damaged the portal vein and they reconstructed it. So the patient was transferred to us, and then we're trying to figure out like what is happening. And you can see that the patient's entire, most of the right hepatic lobe is ischemic. And the interesting part here is that you can see that the periphery of the affected area has a different signal intensity than the center. I don't have a proof for it, but I think that the periphery is ischemic but not completely necrotic. But the center, the parts that are very bright on T2 are like fully necrotic.
That's like your signature sound now, Victoria.
It's just this computer, and I have no idea like why it's doing it or how to stop it from doing it, and I'm very sorry about it, but I'm kind of stuck with this computer for now a little bit. So anyway, so that was one interesting part of it. So if you go back on the delays, you can see that the ischemic parts kind of like almost hyper enhance on the late, and the necrotic parts, of course, remain necrotic. Another interesting part finding here is the MRCP. Sorry. So they did MRCP. They were trying to figure out if the duct needs to be fixed or not. And patient was sick, so the MRCP quality, of course, is suboptimal. But what you can see is this is the distal common bile duct, and then just kind of lose it. So we have this very long segment, we just don't see it at all. And intrahepatic bile ducts here and here are not dilated. So I can't find the ERCP images that the surgeon shared with me for some reason, but basically the ERCP looked exactly the same. There was, and the common bile duct was transected. So the distal common bile, okay, and this is the biloma. Yes, I'm sorry.
No, just a question about the portal vein transection, like that led to this ischemic region. Normally, we think like if there's an acute portal vein thrombus, the hepatic artery takes over and it doesn't get ischemic like this. Do you think it's because it was like literally transected? Like this is almost kind of like a mini Alps of a segment, you know, like where they just like acutely necrose it, or do you think the hepatic artery also got hit?
I don't know. It's a good question. I don't know. Based on the report, they transected only the portal vein, but you
Well,
run,
if they transected the common hepatic duct and the portal vein, I mean, the hepatic artery is in that triad. So I'm with Aarti. I think they
it's
messed up that artery.
it's possible and probable. It's just we know that for sure that they ended up reconstructing the portal vein. So, and there's nothing about it's possible they just tied off the arterial branch that they nicked. But I don't know. It was a very interesting complication that I've never seen this degree of complication from. This was actually open cholecystectomy. So again, you can see distal common bowel we see, and then just kind of disappears into the smoosh. And on ERCP, the smoosh was a bile leak. And they put the stent. They put a stent, and they're going to do Colodoca enterostomy. Okay, and then my last case is just a cute case of this patient had like kind of right lateral hernia with, you can see this is very, very old scan, this one, and you can see that the cecum was going into the hernia sac, and you can, here's the cecum coming out, and then appendix is right here, and you can see it just kind of comes out from the hernia sac and goes up. And this is 5 years, so this one is 5 years later. You can see that the hernia is still there. And then because of the chronic compression of the appendix, you can see that they formed almost like a mucus seal of the appendix there. You can see just from chronic compression at the exit point from the hernia sac right here.
That's very cool.
Yeah, that's cute. The path is all benign, right?
Yeah, it was all benign. I don't remember if there was also superimposed. It may have been. So you can see this is what it looked like 5 years before. This is a cute case.
Do they have to take it out, Victoria?
I think there was, at this point, it was symptomatic and there was superimposed inflammation. But it was, so all this, so I think at this point it also had a little appendicitis situation happening. Okay, that's all I got.
I'm going to try again.
Okay.
So what happens is my alarm goes off on my phone, and then it says that this conference is coming up, and then I'm like, I got to find a case. And so I went into my flag for follow-ups, and I found this one, which now I know it's true, so I can show it to you. And this is kind of interesting because the patient's prior 5 years earlier shows an alternative complication of same, but it's basically things that can go wrong with CSF shunts. And this one, if you follow this CSF shunt, it curls around in here, and then if you follow this part, it ends up, in the lumen of the small bowel. And so it's in the lumen. And when we looked at this, I remember saying, I'm pretty sure it's in there, because you can't get a picture like that without it being inside. And then we looked at it in multi-planes, here it is here.
Oh my God.
Going through, and then here it is here, going through bowel. So the follow-up is, they eventually had to do an exploratory lab, pull it out, lysis of adhesions. I think they did a little like a short segment small bowel resection. And then the interesting part is this patient, I think this was a CSF shunt revision from a prior that had a complication. So interestingly, here's that one. And if you follow this CSF shunt, it goes out the vagina.
Oh my gosh.
So just to say that you've seen some things that can go wrong with CSF shunts.
So are these eroded or are they placed wrong?
I think they're eroded.
Yeah, they erode.
Your body's not as strong inside as we are outside. There's no skin, and things can go wrong because it's a plastic tube up against bowel that is potential to erode.
I have a question. I always wondered why peritoneal dialysis catheters were in that coil, which I thought would prevent them from eroding into the bowel versus VP shunts, they don't put a little coil at the end to prevent that? Anyone have any thoughts?
Maybe it's not as free flowing. I don't know, or absorption wise. I don't know.
Is it possible that the insertion of that peritoneal is different from that seat? They cannot have that.
Oh, because the way that they would have to track it, it wouldn't work.
That's what I'm thinking.
Wait, do the peritoneals, they infuse and remove fluid, right? Whereas the VP shunts are only draining fluid. Would that make a difference?
It might make a difference.
Yeah, I just in general, my IR colleagues, and I believe this too, like whenever you have a catheter with a coil on the end, like a pigtail or whatever, that's much less likely going to be able to erode into a piece of bowel than when you have just like a straight blunt end, right? So, yeah, I just always wondered why VP shunts, but it probably makes sense that they have to like track it from such a long distance that they probably can't have a wire that like is keeping a pigtail coiled, but I can ask them.
We had a paper, we published a paper in AJR several years ago on the complications of VP shunts.
So the article that I was on, I think that what you're showing was a weird title that had something to do with portal flow and polyphlebitis and laminar flow, and I can't remember it was a weird title, but I think this is basically abscesses in a unilateral distribution, probably because it's laminar flow in the portal and splenic or superior mesenteric venous system.
Yeah, that's what we were thinking as well. So these low signal intensity, multiloculated, peripheral enhancing.
It's a CT diagram. It's CT, not MR.
CT. Did I say MR?
Yeah.
Oh. Anyways, and like he said, it's isolated to the left hepatic lobe. So.
In fact, I think I showed Cookie that case when she was here as a professor, and she thought it was pretty cool too.
Yeah, well, that's why Teresa showed the sigmoid colon. I actually read this case, and I told Teresa to show this case because, and to call you out because this is your baby, actually. So
it is now.
And then Teresa should have pulled the paper.
I did, but I started Googling clitoral hypertrophy.
It was published by some GI people as just a case report. It's like through these portals past bad bugs or something.
Wait, I missed something. So is there something wrong with the sigmoid?
Yes. Yeah, I mean, there's an indolent, subacute diverticulitis, because that's what the thing is. These little bugs, sinister bugs, harbor in these ticks for long standing, and then those are the ones that you end up getting the weird complications of these these chronic changes. They're the ones that fishlice the bladder, they're the ones that go to the vagina, they're the ones that give you phlebitis. You can get acute diverticulitis having some having the complications obviously, but it's usually these ugly ones, the sinister ones that kind of fester. So anyway, it's just a nice example of that portal flow from the sigmoid that goes into the left portal. Because most abscesses are the right hepatic lobe, right? That's how we learn most hepatic abscesses, like the right hepatic lobe, because the right portal vein is nice through gravity and it carries the volume of the liver. But sigmoid likes the left hepatic lobe. Kind of interesting.
She found it.
Yeah.
The alliteration, Steve. It's just poetic.
Yeah.
Yeah.
Ours had more abscesses than yours.
Yes.
Ours were larger though.
But it just to give you some credit, I immediately thought about you when I read this case. It was like immediate boom, great case.
It's fun, isn't it?
Yeah.
All right.
I like that diagram. That's cool.
Thanks for sharing. Yeah, that's a cool diagram.
Okay, anyone else? Great cases today, guys. Great to hear from you again, and we'll see you next week.
How was Sabby? Was it good?
Yeah, it was awesome.